So welcome to the Opioid and Overdose session of the Inaugural U of M Injury Prevention Center Research Symposium. I'm Dr. Erin Bonar, and I'll be moderating this session. And thank you so much for joining us here. We're glad that y'all can join us. As a reminder, this session is being recorded and only the presenters and the moderator will be visible on the recording. Our chat function is disabled, so please use the Q&A feature to ask any questions for the presenters. If you have a question for our presenters, please ask it by typing in the Q&A feature in your bottom menu bar at any time. And please indicate who your question is for by including their name at the beginning of your question. Q&A will take place after all of the abstracts have been presented, but we encourage you to send in questions throughout the session so we can have a chance to review them. We will answer as many as time allows. Our presenters will each have 4 minutes to present their poster, and we will share their poster slide while they are presenting. But you may also access their posters and abstracts at the website injurycenter.umich.edu/research-symposium-2020/ for easier viewing. So you can access them from the conference webpage. There are 5 other poster sessions occurring at the same time as this one. And as much as we would like you to stay here and hang out with us the whole time and listen to these great presentations, we understand if you would like to jump between sessions. Recordings of all sessions will also be available in the coming weeks on our website, so you could view things you might have missed. So now I'd like you to join me in welcoming our presenters, our poster presenters. I'm going to introduce everyone now so as not to interrupt the flow of presentations. And so please welcome Emily Passman from Wayne State University School of Social Work, George Gray from the Michigan Opioid Prescribing Engagement Network, that's MOPEN, Dr. Grant Victor from the Center for Behavioral Health and Justice in the School of Social Work at Wayne State University, Jacqueline Kirchhoff from the University of Michigan Medical School, Dr. Jason Goldstick from the University of Michigan Injury Prevention Center, Laura Thomas from the Department of Psychiatry at University of Michigan, and also the VA Center for Clinical Management Research and the Department of Anesthesiology at University of Michigan. Stephanie Slatt from the Department of Internal Medicine at University of Michigan, Dr. Terry Vopel-Lewis from the University of Michigan School of Nursing and Department of Anesthesia and the Medical School. And finally, Miranda Galley from the University of Michigan School of Public Health. Okay, let's begin.
Hi everyone, I'm Emily. I'm from the Wayne State University School of Social Work, and this poster looks at willingness to use 2 different harm reduction programs. We look at syringe service programs and safe consumption sites among people who inject drugs in a small Midwest community. So syringe service programs are places where people can bring used needles and syringes and exchange them for new sterile needles and syringes. And safe consumption sites are hygienic settings where people can bring substances that they've already obtained and then use them under the supervision of trained staff. Both of these programs have been shown to reduce high-risk drug use behavior and related harms, but most studies on use or support of these programs have looked at primarily urban settings. But we know that the impact of the opioid crisis is weighing really heavily in rural and small metropolitan communities, and this could be attributed in part in a lack of access to treatment and harm reduction programs. So right now, most of the syringe service programs that exist are located in urban areas, and we don't have any sanctioned safe consumption sites in the United States. So the purpose of this study was to assess willingness to use these programs in this small community and then to identify factors associated with likely use of each. So basically, we wanted to know, would these programs be used and who would they be used by? So we surveyed methadone patients at an opioid treatment program in a small community about their willingness to use these programs. The agency that we recruited from is located in a small metropolitan area, but it also serves patients from several surrounding rural areas. And for this study, we limited our analysis to only those that reported a history of injection drug use. And we use multivariate logistic regression to identify factors associated with willingness to use each program. So overall, willingness to use both programs was very high. We had 87% that said that they would have likely used a syringe service program if it were available. And then we had 81% that said that they would have likely used a safe consumption site if it were available. Likely syringe service program users on average reported more lifetime consequences of opioid use. So this is consistent with prior research in urban areas that shows that syringe service programs are really successful in attracting and engaging people who are engaging in high risk, high intensity drug use behaviors. And then for safe consumption sites, we saw that lower levels of education and greater self-stigma were associated with greater willingness to use the program. So this shows us that these programs would successfully reach a particularly marginalized subgroup of people that use drugs. So we concluded that methadone patients in this small metropolitan community and its surrounding rural areas perceive these programs to be useful. Our results show increased interest among those who might not be reached by traditional service models. Again, those with high risk drug use behaviors, low levels of education, and higher levels of shame or self-stigma. So this kind of tells us that these programs might create an additional opportunity to connect people with other needed healthcare and social services. So expansions of these programs outside of large urban areas is a really viable strategy to prevent overdose fatalities and the spread of infectious disease in small communities. Thank you.
Hello, my name is George Gray. I was a gap year researcher with the Michigan Opioid Prescribing Engagement Network, where I had the privilege to explore and identify the availability and accessibility of naloxone through pharmacies that participate in the statewide naloxone standing order. Now, a big component of this project is centered around understanding what the naloxone standing order is, and it's designed to make an effective and quick-acting opioid overdose reversal drug, naloxone, widely available for individuals at higher risk for opioid overdose. And it did this by permitting those individuals to obtain naloxone from standing order designated pharmacies without the need of a provider's prescription. Now, a standing order isn't unique to the state of Michigan. Many states, in fact, have similar standing orders. And while we as a state hadn't actually assessed how well ours was working since its indoctrination in 2016, some states indicated that there were multiple barriers that prevented access for those it's intended to help. So to investigate how accessible and available naloxone really is through the standing order, we contacted pharmacies on the naloxone standing order list, which was created and made publicly available by the Michigan Department of Health and Human Services, specifically for 8 counties, and conducted telephone surveys for each pharmacy, assessing naloxone dispensing procedures, out-of-pocket costs, and any educational practices surrounding naloxone use. Now, to sort of take a sidestep, this contacting the pharmacies served 2 purposes. One, it allowed us to get an up-to-date picture on dispensing procedures and the utilization of the standing order. But 2, this project was nested in a larger collaboration with Medic and Michigan Open, where we dispensed 2,400 naloxone rescue kits to 10 emergency departments in those 8 counties. Intended to be sent home with patients that had received care for opioid overdose or individuals at higher risk for opioid overdose. So obtaining data on pharmacies in these particular counties was important for the creation of naloxone pharmacy access cards, which is pictured on the right map there, to be included in those kits. And those contain county-specific lists of pharmacies to show where additional naloxone could be obtained beyond what that kit provided. So in short, the responses recorded reflected similar results to what other states found. And just to note a few, despite being listed in that state data, there were over 50 of the contacted pharmacies that claimed to not actually be participating in the standing order. 37.9 of confirmed standing order pharmacies never really had anyone pick up naloxone through the standing order. And when asking pharmacy staff if they participate in the naloxone standing order, We consistently got a lot of confusion as to what that was. And we heard a lot of like, no, what is that? So despite the initially apparent availability and accessibility of this life-saving drug, we found that 46% of the pharmacies that we were able to survey never actually dispensed naloxone or were uncertain if they ever had. This pointed to our conclusion that barriers to utilization of the standing order exist in Michigan as well, potentially as a result of things like variable out-of-pocket costs, limited pharmacy staff knowledge about the standing order, or lack of public awareness that it even exists. That's what we found. Thank you.
Hi, everyone. So the title of this study was The Factors of Fatal Overdose, Buprenorphine Treatment Uptake, and Critical Encounters Following a Non-Fatal Overdose. My co-authors here were Ms. Katie Bailey and Dr. Brad Ray, both from the Center for Behavioral Health and Justice and School of Social Work at Wayne State. So we know that persons with a prior non-fatal opioid overdose event have an increased risk for opioid-related mortality. And we also know that buprenorphine is a partial agonist and is one of the most effective medications for opioid use disorder. However, a few studies have really investigated whether MOUD reduces the risk of opioid-related mortality following a non-fatal opioid overdose event. So the data that we used for this study is a retrospective study that was conducted on all overdose cases in Marion County, Indiana, in 2017. So that was our pre-period, and then we followed those same individuals who had a non-fatal event through 2018. And we looked specifically at those who were prescribed buprenorphine following the non-fatal event. So the data sources, they're administrative data that were linked from the Indiana Department of Public Health, the Indiana State Police, Indiana Department of Corrections, and the Prescription Drug Monitoring Program in the state of Indiana. The analyses looked at bivariate comparisons, and we also ran two regression models, binary logistic regression models, to look at the main and interaction effects of our covariates. So our results found that of the 10,195 non-fatal overdoses, 2.4% of those, or 247 individuals, resulted in a fatal overdose in the follow-up period. 23%, almost 24% of individuals who were dispensed buprenorphine were also booked into a jail during that 12-month follow-up period. And what we found through the regression modeling is that individuals with an arrest encounter had a 2.16 greater odds of experiencing a fatal overdose in the follow-up period. And we also found that buprenorphine had a strong protective effect against the fatal overdose, where those who were dispensed had a 94% less likely to experience a fatal overdose in the follow-up period. However, when we looked at the interaction effect between individuals who were arrested in the follow-up period but also had a buprenorphine prescription, we found that that protective effect was mitigated. And so far as those individuals with this interaction effect had about a 63% chance of increased risk of fatal overdose in the follow-up period. So we concluded by saying that, yes, linked data sources can have utility in identifying risk and protective factors, but it seems somewhat clear by our findings here that disruptions in care following an arrest, largely due to Medicaid suspension upon arrest, may have interrupted the care, the MOUD care that individuals were experiencing, and thus placing them at a heightened risk, again, upon reentry. We also suggest that greater attention and policy change should be addressed within the reentry process in linking individuals who are high risk with medication-assisted treatments upon their discharge from the jail. And just a quick note, the jail, the county jail that was under investigation in this study did not offer continuation or initiation of medication for opioid use disorder. Thank you.
Alrighty. Hi, everyone. I'm grateful to present today on behalf of my co-authors, Drs. Pilkerton, Lossman, Cranford, and Dahlem. So thank you so much for all being here and for taking the time to discuss such an important topic. As we've heard from a number of other presenters today, the opioid epidemic continues to take tens of thousands of lives per year in this country. This is an immense tragedy, and it's made even more painful by the fact that many of these deaths are preventable. In my talk today, I'll be sharing with you the findings from one such attempt to prevent opioid overdose death, specifically by providing in-person education sessions to medical students at the University of Michigan. The idea for this curriculum arose in 2018 when then medical student Rebecca Pilkerton proposed administering naloxone training as part of the mandatory emergency medicine curriculum for third and fourth year medical students. This proposal came in the context of a recent push across the country to train medical students on naloxone administration, in part because medical students will soon graduate and have the ability to prescribe this life-saving medication themselves. Rebecca worked with Drs. Eve Lossman and Gina Dahlem to develop a 30 to 45-minute training session that covered naloxone administration based on the existing Take Action curriculum for first responders and lay people. In addition to teaching students how to administer naloxone, the training also covered background information about the opioid epidemic, risk factors and pharmacokinetics of naloxone and opioids, and the role of co-prescribing naloxone, among other things. Drs. Lossman and Dahlem taught the training session every month for 1 year to a total of 156 medical students. To assess the efficacy of the curriculum, the students were surveyed before the training, immediately following the training, and 3 months after the training. It's this follow-up evaluation 3 months later that makes our study particularly unique, as most of the rest of the literature just comments on immediate effects of similar curricula. The survey specifically evaluated students' knowledge about naloxone through a series of 7 questions. It also assessed their self-reported feelings of preparedness and comfort to teach about various naloxone and overdose topics using the Likert scale. We used pair-T tests to analyze the changes in knowledge and attitudes across the 3 survey time periods. In terms of results, 119 of the 156 students took the pre-training survey. As seen in the green bar graph, of the 7 questions that we asked about naloxone knowledge, students on average answered 4.8 of them correctly before the training. If you shift your attention to the line graphs to the right, you can see the various preparedness and confidence Likert questions that we asked them as well. I'll expand upon these changes over time in a second. Immediately following the training, 81 students took the same survey again. There was a statistically significant improvement in correct answers about naloxone knowledge, with an average of 6.5 out of 7 correct, as you can see in the green bar graph. If you look over to the line graph, you can see that in all metrics assessed, students felt significantly more prepared and confident immediately after the training as well. 3 months later, 17 students took the survey again. This was an unfortunately low response rate, which is definitely a limitation of our study, but it still provides a window into the potential durability of the effects of an in-person training. Going back to that green bar graph, you can see that students continued to have a statistically significant improvement in knowledge as compared to before the training. As the line graph on the right demonstrates, their preparedness and confidence also remained higher than before the training, with significance persisting in almost all metrics as well. It's difficult to make sweeping claims about efficacy with such a low response rate at 3 months, but these results are promising. Although there was some decay with time in terms of both knowledge and attitudes, many of the increases remain significant after 3 months. We feel that this suggests that effects of naloxone training for medical students may persist over time, and we look forward to continuing to study and expand upon this intervention. Thank you all for your time and attention. I look forward to answering questions.
Jason, you're muted.
Thanks. You might want to be able to hear me. So anyway, this is a project I'm doing in collaboration with the CDC and a couple of people here at the university. As I'm sure everyone here knows, opioid prescribing has increased significantly since the 1990s, and along with that increase, there's also been increases in opioid use disorder diagnoses, hospital admissions, opioid-related deaths, and of course, everyone knows that starting on prescription opioids increases your risk of transitioning to illicit opioids. So for those and many other reasons, the CDC issued a guideline in 2016, a voluntary guideline to opioid prescribers to to make prescribing more safe, basically. And the purpose of this project is really to evaluate that guideline and see if it changed opioid prescribing behavior using a commercial claims database. So the part of the guideline that we're focusing on in this box here on the left, I basically put the 9 elements of the guideline in there, but the part that we are focusing on is starting people at safer doses, namely less than 50 or 90 MMEs per day, and also starting people with the minimum duration required for effective pain treatment. So the data source here is Optum Insights Claims Database. This is, I don't want to go into a lot of detail describing it. Basically, it's a commercial claims database, millions and millions of people, has all their drug fills and other interactions with the medical industry involving claims. So the way that we tried to estimate the guideline effect was to create sequential cohorts. 4 of them are before the guideline was issued, and 3 of them are after the guideline was issued. And this diagram, which you can't see very well on here, but you should look online at the poster and you can see it very well, where it shows basically the cohorts were created by having a 12-month baseline period where we checked to see if there were any opioid fills. And if there were not, meaning the people were opioid naive, then we looked in a follow-up period to see if they received any opioids during the follow-up period, and if so, what dose were they started at and what duration were they started at. And those are the 2 main outcomes right there. So creating the cohorts in this way, and there are also exclusions for terminal diagnoses and some other things like that. So creating these 7 cohorts, they range in size from about 3 to 5 million people. You can see if you look at this table that they're getting older over time, getting less white over time, and a few other trends you can see. But basically, the thrust of the analysis was to use the 4 years of pre-guideline data to estimate the trend and where the trend would be going if the guideline truly had no effect. And then to contrast that with what was actually observed following the guideline. So on this plot here, for example, on the right, you can see the red line is the modeled trend using the 4 pre-guideline points and seeing where you think the guideline is going to go, or where the prescribing trends are going to go from there. And then you can see the blue line is what the actual data was, or the blue curve is what the actual data showed. And you can see here that the actual prescribing duration was far under that estimated by the pre-existing secular trend. And this bar plot here, as you go from blue to red, that's the pre to post guideline period. And if you go to the right, those are higher doses. And you can see the higher doses became less frequent in the later, after the guideline was issued relative to the pre-guideline trend. So the basic conclusion here is that it looks like this voluntary guideline does seem to have changed some prescribing behavior, although of course there are a lot of other things in the landscape that have been changing during that time. But this suggests that a voluntary guideline can be an effective part of changing the cultures around opioid prescribing. Thank you.
Hello, everyone. My name is Laura Thomas. I'm a lab manager and project manager in the Department of Anesthesiology. So I'm going to be talking about how we translated an opioid safety intervention through an iterative website development. So first, we did a study in 2013 in the emergency department with patients with recent opioid misuse and some with overdose experiences. And you can see in this chart here that was also shown by Dr. Bonnert earlier in her presentation that we found significant changes in those who received a brief 30-minute motivational interviewing-based intervention compared to those who only received overdose brochures. So after that study, we ended up getting funding from the CDC and the U of M Injury Prevention Center to translate that emergency department study into an online toolkit so that we could disseminate this evidence-based intervention to a broader population into more clinic sites or organizations. So we added the addition of Naloxone distribution along with that ED intervention and created the opt-in project and website. We did multiple rounds of interviews with community members. First, we did interviews with 16 individuals to find out how we could integrate this intervention into their organization or their workflow, what their background was, and what did their client population look like so we could adapt the intervention to outside of the ER population. We then drafted the website, which is shown here on the left image in the center, and we completed 15 more interviews to get feedback on that site. We did a final 4 interviews that were completed with partners who actually did the intervention and used the website during our research project. In the center here, we found some results. So we found that it was really key to make sure that we could integrate the opt-in session and toolkit within the current site workflow so that it was easiest on the staff who are already usually very busy and have a lot of workload happening. You can see the transition from the image on the left to the image on the right that we definitely got some feedback on the website layout. So we made some adjustments to help in ease of using the site and navigating the different components of it, even if it's a first-time user who's accessing this website. We also discovered that a lot of people are not in front of a computer when they're talking to their clients. So we made materials that could be printed and modified to the needs of the staff for pretty much all of the components that we have available on the site. We found that our 8-hour intervention training was helpful in teaching motivational interviewing, as well as motivational interviewing with the opt-in intervention, as well as how to use the website. And finally, that leadership buy-in was definitely needed in order to make sure that staff had the space and support to do the intervention and could integrate it into their workload efficiently. So the overall conclusions that we found were that the website was built in a way that was easy to navigate and work through identifying and discussing opioid safety and overdose interventions with clients. The opt-in research staff provided a lot of support with MI, screening clients and completing the intervention, which was found to be helpful. And overall, this toolkit was found to help have that conversation with clients about opioid safety and overdose prevention. Overall, the opt-in toolkit increased our capacity to share that evidence-based intervention to improve opioid safety and reduce overdose experiences with a more broader population. So that is it, and I want to thank our community partners, all the participants, the investigators, research staff, and our funders for their help.
Hi, my name is Stephanie Slatt, and I also want to shout out my co-researcher, Ivani Ganti, who's in attendance today, as well as our faculty lead, Dr. Pujala Gassetti. This project was centered on opioid policy and chronic pain treatment access experiences and was conducted as a qualitative study. So approximately 10 million Americans are on long-term opioid therapy for chronic pain, and primary care writes the plurality of these prescriptions and provides a substantial amount of service to this patient population. As we know, opioid prescribing is a highly regulated and legislated area of practice. And anecdotally, we've seen some reports that patients are unintentionally being left in the wake of these new prescribing policies. Empirically, previous audit studies by our team has also shown that over 40% of primary care clinics are unwilling to continue prescribing opioids for a new patient who presents already on the medication. So we conducted qualitative interviews with patients, clinicians, and office staff to answer this main question: what range of barriers to high quality care exists for patients with chronic pain, and what have the impacts of new prescribing policies been? Clinicians and office staff were recruited by calling the previously audited primary care clinics in Michigan, and adult patients with chronic pain who had experienced difficulty receiving opioid medication were recruited through both posted flyers on the U of M medical campus, as well as through U of M's health research recruiting interface. Our final sample included 25 participants, 15 patients, 7 providers, and 3 office staff. So we found treatment access barriers were attributed to 5 major themes. The first being reduced clinic willingness to manage prescribed opioids for new patients versus established patients, including issues like not accepting these new patients, not prescribing for them, or having a set wait period before a clinician would prescribe for a new patient. We also found systemic barriers to delivery of high quality pain care. These included insufficient consultation and collaboration between providers, patients feeling like they were managing their own care, or insufficient reimbursement for time intensive care. Fear of liability and the use of new guidelines to justify not prescribing opioids on the part of providers was also found. A prevailing sentiment among clinic participants being that they felt they're being closely watched and that it's often not worth the trouble to prescribe. We also found delayed prescription receipt due to prior authorization and pharmacy issues. These logistical delays being frustrating for both clinic and patient participants and increasing obviously the risk for patient withdrawal. And finally, we found poor availability of effective non-opioid treatments. So patients feeling like available non-opioid options were insufficient, such as being offered Tylenol or heating pads, while providers cite issues in accessing specialty pain management services, both in terms of geography and insurance acceptance. So synthesizing these themes, we propose a conceptual model of treatment access for patients with chronic pain seeking access to primary care. So while individual pathways to effective treatment differ, we identify multiple stages where patients can encounter barriers as they seek access to primary care, as they engage in care planning with their clinician, and as they initiate treatment. While contextual factors could also affect care access at any of these points. So wrapping up, in what ways do these access issues create potential for patient injury? So our first point is that primary care is a really important point of referral for other pain-related services. Second, primary care is also a critical point of engagement for opioid use disorder. And so if clinicians are not seeing this patient population in clinic, it's hard to screen and diagnose for opioid use disorder if it exists. And then third, this also leaves the door open for other negative opioid-related outcomes for patients with chronic pain, such as withdrawal, suicidal ideation, and poor management of their pain in general. So thank you so much for your time, and thank you again to the Injury Prevention Center.
Dr. Vopoulos, you are muted.
Thank you. Sorry about that. I undid my video, but not my microphone. So thank you for having me present my research today, which is funded by NIDA. It's the effect of just risk messages on parents' decisions to retain leftover prescription opioids. And for this brief presentation, I'm going to highlight some of the key elements of our intervention that aren't necessary, that you don't have access to in the poster and in the abstract. And then I'll highlight the main findings. We designed an intervention to address the important problem that the presence of leftover prescription opioids poses to children and teens and others in our communities. As you all are well aware, leftover opioids pose the significant risks of unintentional and intentional exposure and poisoning by children and teens. We believe that in order to reduce the volume of risky leftover opioids, in addition to some of the other things that have been talked about, like reducing prescriptions, and disposing of those medications, those leftover medications, that we believe that it's important to intervene with parents who may unknowingly expose their children to the risks by keeping these drugs around their homes. Since most parents don't want to cause children harm, we sought to educate them by primarily raising their risk awareness and their perceptions. And our purpose was to see if our intervention would specifically enhance their opioid misuse risk perceptions and improve their disposal intentions and behavior. Our intervention was designed to enhance what's known as GIST representations, that is the bottom line meaning of risk information. We know from literature that verbatim or risk rate data can inadvertently lower risk perceptions, especially if the rates of bad outcomes are low, such as 1 in 100,000 children are harmed by exposure. GIST information, on the other hand, provides only the bottom line information, that is, children and teens have died by exposure to leftover opioids. This type of messaging might better enhance the perceived riskiness and therefore be preventive or protective. We created an interaction intervention and tested it among parents whose children were prescribed an opioid after surgery. Specifically, our intervention provides parents with a scenario description, asks them to make an interactive decision, and then we provide tailored feedback for that specific scenario. At baseline, we measured parents' perceived riskiness of child misuse and keeping and sharing leftover opioids in the home. We randomized them to the intervention and then reassessed their risk perceptions at days 3 and 14 after surgery. We also assessed their disposal intentions, whether or not they planned on disposing. And then we finally asked them, after their children were done with their short-term use, we asked them whether or not they actually disposed. We found that our STOMP intervention group had increased perceived riskiness of the riskiness of keeping and sharing opioids and the perceived riskiness of child misuse. We also found that our STOMP group had much greater intention of disposing, and then finally, they had much lower retention rates of their child's leftover prescription opioid. And as an aside, we also found that parents' past behaviors, whether they kept a drug in the house and whether they had misused a drug themselves, actually increased their retention rates. So we found that this was important to then target parents or anybody who gets a prescribed opioid before they ever misuse it. We think that widespread implementation of similar interventions could effectively remove 6 to 12 million leftover opioid doses annually. And we also think that adapting this intervention has the potential to reduce diversion and misuse of other controlled medications as well. And I just want to thank our research team, Dr. Carol Boyd, Sean McCabe, Alan Tate, and Brian Sigmund Fisher from the School of Public Health. Thank you.
Hello. I want to just quickly shout out my co-authors, Vidisha Ghosh and Dr. Dalam, who were co-authors on this project. For our project, we were examining how to broadly disseminate our naloxone training to community lay people and first responders. As you know, naloxone is an effective public health intervention for opioid overdose, and community lay persons are often first to a scene of an overdose. To increase dissemination of our in-person naloxone training, an online naloxone curriculum was built in collaboration with our community partners, Home of New Vision and the Washtenaw County Sheriff's Office. As of October 2020, 487 laypersons and first responders have taken this online training. For the purposes of our current project, we evaluated the initial community layperson data to understand the impact of our online naloxone training. At the time of our data collection, 136 participants completed both pre and post-test surveys. The age range of our participants was between 18 and 70 years. Participants came to the training from a variety of fields and workplaces, including local CMHs, libraries, nonprofits, food service organizations, as well as participants from within the UMich community. A small percentage of our participants had used naloxone to save a life in the past, accounting for 7% of the total CLPs or community laypersons to date. The majority of our participants also had not received a training on naloxone prior to our intervention, which accounted for 74% of CLPs. Our online training was designed so that each participant took a pre-test, followed by online modules and a post-test after the training. This training encompassed 25 different modules for the CLP to work through, including topics such as why do you need to take action, how long do opioids last in the body, and how do I use naloxone. Survey questions assessed knowledge, belief, and attitudes towards naloxone and feelings of preparedness to use naloxone. Descriptive statistics and paired sample t-tests were used to analyze the results. We found that statistically significant differences were between pre and post measures for all domains. Knowledge questions were some of 11 questions, and attitude and belief questions were measured on a 5-point Likert scale. The largest effects were seen on the total knowledge changes, but significant changes were seen on people's attitudes and beliefs about use of naloxone during overdose, along with preparedness to administer naloxone in the event of an opioid overdose. Participants were asked to respond to different attitude-based statements, and they were told that there was no wrong answer. These statements were, if I administer naloxone, I am enabling the person to continue to use more drugs. I believe using naloxone will delay entry into drug treatment, and I am afraid I may cause harm if I use naloxone on someone. So this online naloxone training not only had statistically significant changes in knowledge, but we impacted participants' attitudes, beliefs, and feelings of preparedness. As we know, overdose as well as naloxone use is highly stigmatized. For example, many individuals who may use naloxone, or many individuals may view the use of naloxone as enabling. In reality, we know overdose is a highly traumatic and very uncomfortable experience, which individuals who use drugs do not wish to repeat. So the participants in the layperson training experienced significant means reductions in their responses to attitudes and beliefs about naloxone. This project tells us that an online naloxone training is effective for preparing and educating community laypersons who may encounter individuals experiencing overdose in their communities. We find this to be particularly salient given the current coronavirus epidemic, as more and more community trainings need to be switched to an online format. Within this training, individuals in a variety of settings will have access to critical information at their own time and pace. This website is still operational, and we are currently in the process of making edits to reflect how access to naloxone, updated information about new drugs, and COVID-19 guidance impact responding to an overdose. Thank you so much.
All right, thank you to all of the presenters for this super informative session. It was really interesting to see the span of work in terms of the populations and the settings that this work is taking place in. We do have time for some questions, so we'll be asking the presenters to turn their cameras back on while I moderate and ask you to respond to some of these questions. All right, and I will jump in if anyone leaves themselves on mute, because I know what that's like. So I think I'll start actually with a question for Miranda, who just finished up. It's sort of the recency effect there. And I just wanted to hear more about, in this training, we were interested in hearing about how it could maybe be adapted to different audiences. It's very community driven right now. Are there any plans to maybe tailor it for youth or individuals in specific professions?
Yes, so our training is, we have another training specifically for first responders. So that population is one that we have tailored a training for. Our in-person trainings are usually tailored to organizations. So we'll go into the community when we used to be able to do that and tailor our presentation to those community orgs and the needs they have. We are also looking to hopefully get a training in place for health professionals. So there's kind of a standard general training, and then it can be adapted for the needs of the population.
Great. There's a lot of exciting work that's going to take place. Okay, let's see. Let's take this next question to Jacqueline with regard to the program that you presented. Could you speak to some of maybe any of the barriers in implementing this in-person training?
Sure, yeah. So initially, some of the barriers were figuring out which department would have oversight of the training. It's also something we're sort of wrestling with now too, looking forward. You know, how can we make this something that hopefully lasts into perpetuity? Medical students rotate through a ton of different rotations, and so especially as we are kind of later in our med school careers, there's a little bit less continuity and shared curriculum between students at baseline. So we ended up putting it in the emergency medicine curriculum, number one, because it felt sort of appropriate topic-wise, but also because it's a graduation requirement for all of our students to make it through emergency medicine. So it kind of made sense there. And now we're sort of thinking, looking forward, where can it be hosted perhaps more permanently?
And that might speak to a follow-up question that we've got, which is what are ways to either, you know, combat that decrease in knowledge over time, or maybe to enhance knowledge or keep it going. And I know specifically here in our medical school, you know, a few years ago we revised curriculum and there's more sort of ongoing training early. So I guess wondering how are those ways that you can like have that stick with medical students while they're learning so much, right? Like there's so many things and so much change during that time, but we want that knowledge to carry through. What have you all thought about that?
Yeah, exactly. I mean, it's a great question. You know, when we're thinking about educational theory, the concept of spiraling comes to mind, where students sort of revisit similar information, but in a slightly different context to hopefully help make it stick. And that's definitely core to the medical school curriculum overall. It's just this, you know, first you read about it, then you see a patient, then you get tested on it, et cetera. So what we've been thinking about is whether we can, in some other format, kind of reintroduce this information. There's one particular time point that we've been discussing as a team, which is that prior to graduation and prior to starting residency, all medical students go through what's called a residency prep course. And it's tailored specifically to their future specialty. And so perhaps bringing some of this content back in and helping to teach about, you know, what will your role be as an anesthesiologist or, you know, as a primary care physician, et cetera, and reintroducing this information then, which will hopefully improve retention and also just be another touch point to provide the information. It'll probably have to be online given the current context, but we do have it recorded, which is exciting.
Yeah, there's a lot of things that the current context affects, but thank you.
Of course.
All right, it looks like someone has typed in a question also for George, specifically asking more about the cost of naloxone and how cost might affect people obtaining it.
Yeah, sure. So to Terry's question, I wish it was a more clear-cut answer to that, and it's certainly a potential contributor to why we're seeing such a low utilization of the standing order. There are a lot of factors that'll predict that cost, namely the type of formulation that's carried by the pharmacy. For over the 600 pharmacies that were surveyed, there were 3 common formulations that came up. That's generic intramuscular naloxone, which is injected. That was the cheapest form. There's Narcan, which is the nasal popular one. And then there was Enviso, I believe, which is a auto injector, which is horrendously expensive, but the costs range from about $35 to $3,000 to $5,000 for the Enviso auto injector. But another variable that made it very inconsistent with getting such a seemingly simple question when asking the pharmacists and pharmacy staff is that they're very, and this kind of goes into one of the barriers we had with talking to the staff available was they were very protective of the information that they were giving out regarding naloxone. Not sure personally why, because of the standing order, literally anyone can walk in and request it. So it doesn't seem like that big of a deal to, tell somebody that who's calling for academic reasons. But yeah, there are also coupons that can be that can come into factors. There's insurance coverage, which is what Gina was talking about in the chat there. But there's a huge range and variability in terms of cost, namely on the formulations that's available and insurance, and then whatever coupons that they may or may not apply at the time. But there's a huge variability in out-of-pocket costs. Yeah.
Absolutely. And we've had some other work that has shown there's a lot of disparities in accessing naloxone as well in terms of racial minorities as well as geographic disparities. So combine that with pharmacy policies, attitudes, all of that, you can get a not so simple situation. And so maybe related to thinking about belief systems and things that might affect people who are in need of naloxone or other programs, I think we have a question for Emily. The study, it looks like it found that lower education and more self-stigma affected willingness to use a safe consumption site. And this is pretty interesting given what we know about education, stigma, and help seeking and health in general. What do you attribute the findings of this to in your study?
Yeah, so those findings were really surprising to us. As you said, usually a lower education or more stigma can be associated with poor health outcomes or could be barriers to seeking treatment. But we think that safe consumption sites are different in the type of services that they provide and the way that they provide them. So people who have greater levels of shame or self-stigma, for example, might welcome the opportunity to use substances in a confidential setting away from their friends or family or roommates. So that's kind of what safe consumption sites do. They give people a place where they can do that privately, but without incurring that extra risk of using alone. And then we also think, and some previous research shows that safe consumption sites are perceived to be more useful or more attractive than traditional mainstream healthcare settings, so that those associations that we see with traditional healthcare settings might not apply. So I think our findings kind of suggest that people really perceive these programs to be environments of unconditional positive regard, which is great.
Mhm. Yeah, there's maybe some stigma around, or a belief, sometimes a myth, that people who are injecting drugs don't care about their health. And choosing a safe consumption site, right, is an indicator of caring about health, right? To be doing it in a place where you can take care of yourself and have someone there to help you. So it's a really interesting study, and thank you for answering this. Maybe the next question is for Grant, and maybe you could talk about how the lack of incarceration institutions, lacking currently providing medication for opioid use disorder, and what can be done to maybe facilitate the linkage to treatment upon release.
Yeah, sure. So we know that roughly fewer than 1% of incarceration institutions offer MOUD of any kind, let alone all three FDA-approved medications. And among those that do, many of them may only offer naltrexone, which just does not have the same evidence of effectiveness compared to buprenorphine or methadone. So for the purpose of the question, let's just assume that will remain the case for the near future, but hopefully not. So when you're talking about reentry, from our study and other evidence, I think these policy reformulations and interventions should address detainees' incomplete knowledge about MOUD and facilitate their linkage to care prior to release. So for instance, some participants may have negative experiences in taking illicit buprenorphine, and that may be down to the fact that they were using buprenorphine in conjunction with other opioids, and therefore, precipitating their withdrawal. So using some psychoeducation on that front, and there's also a sort of a new front in patient decision guides, patient decision aids that are centered around MOUD care, and we're actually working on developing one for justice-involved individuals. So I think one part of it is education and bringing individuals to up to speed on the information of these medications. But I also think the innovations need to address reentry conditions that are a lot more complicated. This includes housing, this includes employment opportunities, transportation. All of these things really play a critical factor in terms of linking to care. So because if you're not linking them, or if you are linking them to care, of course, but they have no way to get there, or they have other needs that are more salient for them, they may fall into some chaotic use pattern. So I think it has to start with the linkage to care and education, but it also needs to be more holistic and address the root causes of drug use.
Right, and it seems like you're really thinking about the systemic root causes of drug use. There's a lot of onus placed on the individual. If we just educate the individual, they'll do what they need to do. And we know that the problems that occur and how these things affect individuals' lives are much larger than that. And that, there's also potentially room for those multi-level interventions beyond the patient or the detainee specifically. So thank you for addressing that. It's important. Looks like our next question is for Jason. So Jason, your data set's a little different than some of the others that we looked at, right? And so looking at claims data specifically, so data on insurance claims. And so what we are wondering here, as we think about that data source, is how that population is either different from or reflects, a general patient population, and in what ways?
So yeah, it is very different from a regular population. I think people use data like this just because it's available, and it's one way you can track over time people's prescribing and their outcomes and everything like that. I think obviously one of the big issues with claims data analysis is that the people who are in those databases obviously have insurance, which means they are obviously able to afford insurance, or they might have more stable employment, for example, or might or maybe if they're younger, then their parents might have more stable employment. They're under their parents' plan, so it's obviously a higher SES kind of population than if there were data on people that weren't restricted to those with commercial insurance. And then, of course, a lot of the people in this database also have Medicare. So in some ways, this population might be a little older than a general population. So those are some of the big concerns. And of course, another problem with the analysis is that not every people might have a different source of insurance that they make claims with, or they might be paying in cash for some things. So there are definitely some possible missing of opioid claims, which is one reason why there's probably some percentage of the people that are declared opioid naive by our data that probably were not. So I mean, that's probably one of the main misclassification issues. But just as a general study population, it's definitely higher SES than the real population. So that's the main thing. I mean, so that the whole any kind of conclusions surrounding that is kind of more like, well, if the CDC guideline did impact the norms surrounding prescribing, then the data only suggests is limited to the fact that, well, we know that it impacted the norms, or maybe impacted the norms among the higher SES people. So those are some of the limitations. There's probably some more.
That's an important thing to keep in mind with claims data, right? That it's not it's not fully generalizable to some of the other populations we're talking about here. So it's again important to represent multiple perspectives. I'm hoping to squeeze in just a couple more questions. There's still some more, and I actually I'm going to take advantage of asking a question myself that I have, which is for Terry. So Terry, I was just wondering, your intervention sounds really exciting, and there's some really great results there, and I missed it, or maybe you didn't got to it, but I'm wondering if you could describe the length of the intervention and how to integrate that into busy healthcare systems.
So that's a really good question. And actually, our intervention is really, really brief. And it was originally designed to address multiple different aspects or risks of opioids. So for instance, we have several short scenarios. The data that we presented here really addressed one scenario, that was what happens when your child is now recovering. They haven't taken the opioid for a few days, and you have this leftover medication. What are you going to do with it? But the way our intervention worked is we also gave other scenarios. So for instance, we have a scenario where the child is in pain and needs an opioid. They have this opioid prescribed to them. Are you going to give the dose, yes or no? And then we also describe another child in pain, but also has significant oversedation. So our intervention was meant to address parents who get a prescription for their child and the decisions that they make around that. And we believe that this type of intervention could be used for lots of different medications, but we were interested in two scenarios: the oversedation scenario, how do you get parents to recognize oversedation? And secondly, how do you get them to recognize the risks of keeping a drug around? And each scenario takes a couple of minutes for the person to review, and then they make a decision, and then they get feedback. And the feedback is meant to be given. We have two ways of giving feedback. One is prose and one is in video. And the videos were developed by Stamps, and those are really addressing some other things around misuse. So you could give the intervention in the clinical setting prior to going home. You could send push notifications to them. Ideally, they would get a push with a message to throw the drug away at about 7 to 14 days. And that's how we would test it that way in the future. But right now we just tested them getting the intervention at the time of prescribing.
Great, thank you for that description. And it's really shows that there's more work to be done while also being able to, maybe change clinical care sooner rather than later. And so I did not have time for a last question or two that came into the chat, and I want to apologize for that. It is time for us to begin wrapping up. So I just want to, again, thank you all for joining us at the Inaugural Injury Prevention Center Research Symposium. And a huge thank you to all of our presenters here. If you do have questions, my guess is they wouldn't decline an email from you. And I also want to thank the staff at the Injury Prevention Center, specifically Lisa Orison and Amanda Ballesteros, for making sure that this went smoothly. I thought it went pretty smoothly, so that's amazing. As a reminder, all sessions today were recorded and will be available on our website in the coming weeks. You'll be receiving a feedback survey within the next week, and we really encourage you to fill it out and help us continue to grow and improve this event in future years. We actually listen to the feedback, so please give us the feedback. We take it into account in planning these events. Further, if you're not already a member of the Injury Prevention Center, please go to our website at injurycenter.umich.edu to become a member and to get access to our monthly newsletter with publications, updates, and events. We also want to encourage you to attend our Suicide Prevention Summit, which will be held virtually on March 16th. You can RSVP for this event by going to the events page on our website, and you can also begin submitting abstracts to this event too. Please, again, check out the website for more information and opportunities that might interest you or your colleagues. We have a summer internship program. We have massive online open courses, lots of resources out there for this community. And again, thank you for your attendance. Thank you to all of our presenters for their work, really important work on injury prevention. And I hope you all have a great rest of the day. Thank you.